Our last speaker of the day is Dr. Tony Fauci. Dr. Fauci, I got to know as a young nephrologist when I read his papers on how to approach the treatment of angiovasculitis when he was interested in those autoimmune diseases. He's going to tell us an inspiring story of his engagement as a physician-scientist in new and emerging infections, especially those that affect us in the developing world. He's a winner of the Canada Gairdner Global Health Award this year. That's a new award for Gairdners in the spirit of us. It's quickly been recognized as the preeminent award in the developing world in global health. It's awarded to a scientist whose advances have or will potentially have a significant impact on health outcomes in the developing world. I know Dr. Fauci through many different ways, as many of us do. For instance, he's the lead editor of Harrison's textbook of internal medicine. He's been an inspiration for those wanting a career in physician scientist. He reminded us yesterday when he gave medical grand rounds to the Department of Medicine that he's trained many of the leaders of academic medicine on a global basis, 75 and increasing. He's won many prestigious awards, for instance, National Academy of Science member, Presidential Medal of Freedom. He's an advisor to many of the past presidents, and I'm sure that his wisdom and insight will be a guide to future presidents of the United States, whoever she will be. It's our pleasure today to have him give his talk today over his personal journey in 30 years of global health. Welcome, Dr. Fauci.
Thank you very much, Phil, for that kind introduction. It's really a great pleasure to be here with you this afternoon, and I want, as my fellow awardees mentioned, my deep gratitude and appreciation for the honor of receiving this award from the Gairdner Foundation. I'm going to talk to you today about what is said on this first slide, namely a personal journey that I've had the privilege of experiencing over the last 35 and more years in the arena of global health. But I want to particularly direct some of my comments to the younger people, students and fellows in the audience, with some lessons that I've learned over the years about the unpredictability of one's scientific career and how one makes use of opportunities that come to you in an unexpected way. So all of us come to our careers in science, particularly because we're scientists, really from different perspectives. My perspective is one that I'm going to talk about that really is in the field of medicine and as a physician. And as I'd like to divide my comments into three separate components of my life and how they all interacted ultimately in getting me to the point where I am now devoting my career to the issue of global health, for which I am so gratefully honored for today. And the division of my three hats will be as a scientist, as the director of the National Institute of Allergy and Infectious Diseases, which funds the vast majority of infectious diseases research in the country and in some parts of the world. And then finally, the privilege I had of participating in the development of an important global health program. So let's start right off with the issue of my career as a scientist and how that informed any kind of contribution that I might have to global health. The perspective from which I come is one as a physician. This is a picture of me a long time ago as a chief resident in internal medicine at the New York Hospital Cornell Medical Center. And the reason I show it to you, besides the fact that I want to tell you that there was a period of time in my life that I did not have gray hair, is that that is the perspective from which I view everything, from the standpoint of medicine and health. You can do as much basic science as you want and not necessarily be a physician, or you can be a physician and use basic science to answer some of the questions that you need. So my perspective has been from one of a physician. After my medical training, I went to the National Institutes of Health to do a combined fellowship in infectious diseases and immunology. And the reason I tell you that is because, unbeknownst to me at the time, that dual training in both infectious diseases and immunology was the reason why I wound up getting involved for the last 35 years in studying HIV/AIDS. Now, Phil mentioned to you that he first got to know me because when I finished my career training in immunology, I was drawn towards the study of autoimmune and inflammatory diseases even though I was clinically trained as an infectious disease person. So I was fortunate enough to have mentors that put me on a project where we developed successful treatments for formerly fatal diseases, such as the inflammatory vasculitides and a variety of other diseases. So by a combination of being lucky, being in the right place at the right time, and having a very, very generous mentor, I became reasonably well known as a scientist involved in the arena of inflammatory diseases. But at the core, I was interested in infectious diseases. Now, I want to show you just these very briefly. These are a list of the papers that I was involved in studying and publishing in the years from 1972, when I left my clinical training and went to the NIH, to 1981, when something very important happened. And the reason I show you these papers, because I was inadvertently, without realizing it, training myself for something that I would be doing 9 years later. And what do I mean by that? I was looking at the dysregulation of the immune system. If you look at the title of these papers, cytotoxic effector cells, polyclonal aberrant activation, the effect of immunosuppressive agents, the spectrum of inflammatory diseases, immunoregulatory cells and polyclonally activated diseases. Now, this was 1972 to 81, and little did I know that there would be a disease on the horizon that would actually be characterized by dysregulation of the immune system. And this is a slide that I show whenever I talk about anything I do, because it are two publications from the Centers for Disease Control and Prevention that essentially changed my entire professional life, and in fact, my life in general. And I remember very clearly sitting in my office at the NIH in the summer of 1981 when the first MMWR, this one here, reporting 5 curiously gay men from Los Angeles who presented with an unusual pneumonia that you only see in people who are immunosuppressed. I didn't make much of it. I thought it was a curiosity. And then 1 month later, I read the second paper, which was now a report of 26, again, curiously, only gay men who presented not only with pneumocystis pneumonia, but with Kaposi sarcoma and a variety of other opportunistic infections. And that was the first time in my medical career that I actually got goosebumps, because I realized that we were dealing with a brand new disease, because I had been studying infections for the previous 9 years, and I had never seen anything that even remotely resembled this. So I made a decision. Now, it turned out to be a transforming decision for me, and to be honest with you, I can't tell you precisely what the thought process was in my mind that made me make that decision. But I decided that I was going to stop what I was successfully doing for 9 years and turn around the direction of my career and start studying this very unusual disease, much to the dismay of my mentors, who thought that I was throwing away a very promising career, saying, "Why do you want to study a group of gay men who have a disease that likely is going to disappear because it's not very important?" So this was my lab at the time, all individuals studying immunoregulation. And I decided, I told them, for those of you who want to join me, we're going to change the direction of what we're going to study. Now, because my mentors were very concerned that I was making a professional mistake, I decided that I would write what I refer to as my Apologia Pro Vita Sua. So for those of you who didn't take Latin in high school, that means that is an explanation for what you're doing with your life. And my Apologia Pro Vita Sua was in a paper that I sent into the New England Journal of Medicine. And they rejected it because they said they thought it was too alarmist. So I sent it into the Annals of Internal Medicine. And then they accepted it. I wrote it in the winter of 1981, and it didn't get published until the spring of 1982. And at the time, there were 159 reported cases of AIDS in the United States. And what I said in that paper was, because we do not know the cause of this syndrome, any assumption that it will remain restricted to a particular population in our society is truly an assumption without scientific basis. Now, unfortunately, that was very prophetic, because fast forward 35 years, and there have been 80 million infections with HIV, 40 million deaths, and 37 million people living with HIV. Now, what happened over the ensuing months to years? Unfortunately, my prediction was correct, because we found out it wasn't only in gay men. We saw it in Haitians, which were really heterosexual. We saw it in hemophiliacs and those who received blood transfusion. We saw it in heterosexuals, in women, and in infants born of women. In fact, it was an infectious disease that was transmitted predominantly sexually, but also by blood and blood products. And then what happened was the beginning of another phase in my career. I had been at the bench doing bench research for 9 years, but these patients were so sick that I was spending 85% of my time on the ward taking care of desperately ill patients with very little time to be in the lab. And when I was, it was into the middle of the night, because we spent most of the time taking care of patients. And this is a picture of me on our typical rounds, which lasted hours and hours because of the extraordinary depth of the seriousness of the disease. So then what did we do? This is interesting, and I really point it out for the students and the fellows in the audience. We didn't have a virus. It was 1982-3. The virus was discovered in 1983 by the French and shown to be the etiologic agent in 1984. So what we did is what we do best. We studied the regulation of the immune system. This was the first paper that I published on HIV/AIDS before it was HIV. And what it was the first demonstration of aberrant immune hyperactivity in AIDS. I like this paper because it's an example of get your data and publish it, and you may not know what the ultimate significance of the data is at the time you publish it. But this turned out to be the first demonstration of aberrant hyperactivity of the immune system, which now, 30 years later, is quoted as the paper that proves that hyperactivity of the immune system is the driving force of HIV replication, because it replicates in an activated phenotype of the immune system. So now I'm getting credit for an observation in which I didn't even explain it in the paper that I wrote, but it is now quoted as the paper that has proved that. Very interesting. Well, you'll take what you can get in science. So then we went on in studying the defects of T cells. And it was very interesting because I titled my talk in the first slide, A Journey. And it was really an extraordinary scientific journey as we were making observations, some of which turned out to be incremental and relatively trivial, and some of which turned out to be very important. For example, on the right-hand side of the slide, the first demonstration of that there is a reservoir of virus in an individual, which is the major stumbling block in curing HIV. We found that memory CD4 positive T cells were the major preferentially infected cells, another observation that ultimately turned out to be more important than we thought it was at the time that we published. I always suspected that there would be more than just active virus replication. And back in 1986 in Science, we published the first model of HIV latency, which led to an understanding of the reservoir in individuals who are treated who no longer have active viremia, but who still have virus in their body. We looked at the reservoir and found out that it was a misperception that you had to be infected for a long time to develop a reservoir of HIV, and we showed that in the very earliest stages of the infection, the reservoir is formed. We then made an observation that turned out now to be the general paradigm of why you have persistent virus replication. And it's a diabolical thing that the body's own response to the virus activates the immune system, which drives virus replication. So it's an autocrine and a paracrine phenomenon where the cytokines that are normal endogenous cytokines like TNF alpha and IL-1 beta are the driving forces of HIV replication. And as shown on this slide, the positive control is anti-CD3, but if you have a combination of endogenous cytokines like IL-1, IL-6, IL-2, TNF alpha, you can drive virus replication. So the virus is a very clever virus in the metaphorical sense, in that its stimulation of the immune system is the very factor that drives its own replication. We then found out something that was very sobering. People looked like they were clinically latent. In other words, we found out when we tested people broadly after we got the HIV test that some people were HIV infected, but they looked well and they didn't look like they were sick. There was a false assumption that there wasn't a lot of virus replication going on until we looked in the lymph nodes and found out there was copious virus even when individuals were relatively asymptomatic. And what that meant, that although they looked well and they felt well, there was a very insidious, relentless destruction of their immune system. And then we went on to study the reservoir, the most problematic aspect of curing HIV-infected individual. When we got good antiretroviral therapy, we had years of suppressed viremia. We thought with a little bit of confidence that that meant if we kept them aviremic for several years, that in fact the virus would disappear. No such luck, because what we showed first in individuals who were aviremic, that when you took their cells out, we got replication-competent virus out of everybody. So even though they were aviremic, they still had replication-competent virus. We proved this empirically by stopping therapy in individuals who were suppressed with their virus. And to our great dismay, this paper and this slide is one of the most depressing aspects of my studies over the years. Every one of the patients rebounded with viremia. Years later, this paper was done in 1999. Every other investigator who's ever tried to stop therapy in people who've done well, it has rebounded in every single individual. We try to flush out the virus by activating the immune system. Again, we were disappointed. We couldn't detect the reservoir. I was very careful in saying I don't think this is a cure. The reservoir was undetectable in the blue bars. We did PCR, we got some signal, we couldn't get replication-competent virus. We thought it was dead viral, proviral DNA. It wasn't, because when we stopped therapy, in the red line, all of them rebounded, and in the blue bar, the reservoir returned to its pre-treatment level. Again, more discouraging. We showed that the B cells were dysfunctional in HIV, which makes it very clear why the body doesn't make a very good immune response against the virus. And then most recently, literally, as of just these past couple of years, we discovered a new receptor for HIV, the alpha-4 beta-7 integrin, which is very important because that's the homing receptor for T cells to the gut, which is one of the major sites of HIV replication. And just a week and a half ago, we published a paper in Science which showed for the first time that when you passively transfer of antibody to alpha-4 beta-7 in a non-human primate model, you can discontinue therapy, and for up to 2 years, we have not seen rebound of virus. That's the good news. The sobering and humbling news is that we don't know what the mechanism of that control is. We suspect that we've actually induced an immune response that natural infection was unable to induce. So that's the scientific aspect of what I have been doing as part of this journey that interdigitates into global health. So what's the next step? The next step was an issue that was another one of those things where I made a decision that I actually had some trepidation about. And that is, I was offered at a very young age the directorship of the National Institute of Allergy and Infectious Diseases, which was a little bit anxiety-provoking because I was afraid that was going to take me away from what I do and like, is taking care of patients and being in the lab. So I decided that instead of stopping something, I would add something on. And that's what I did. And I became the director and have been now for 32 years. It turned out, I feel badly now because I used to be the young kid on the block, and now I'm no longer the young kid on the block. I was the youngest institute director in the history of the NIH to get appointed at a very young age, which was really great at the time, but now, unfortunately, I'm the oldest institute director at the NIH. But what I did is that I took it on with the provision that I would continue to see patients and that I would continue in the lab. But why would I take a job with administration when I fundamentally don't like administration? And the reason I did it is that I thought that we were not addressing the HIV/AIDS pandemic in the way that I thought we should. Because remember, I took the job in 1984. HIV, the AIDS epidemic, was first recognized in 1981. So I did it, and I did it because it gave me an entree into having some influence on the policy of how we address outbreaks. Outbreaks in this case was HIV, but as Frank mentioned just a little while ago, we've had subsequent others since then that would have been important and part of what I've done. Now, the beauty of this and the fun of this, and sometimes the thing that's a bit anxiety-provoking, that it introduces you into areas in life that you never expected you'd be doing. So this is a picture of me testifying before the United States Congress. I have some dubious distinctions. One dubious distinction, and I checked this out with the congressional record, is that I have testified before Congress more than anybody else ever, 247 times. And the reason is that the Congress is very interested in things like outbreaks. I've done a lot of it with HIV, but a lot of it with Ebola, with Zika, with H1N1, with all the things that Frank spoke about. Now, the beauty of this is that you get a real lesson in civics. So if the president is Republican and the Congress is Democrat, you get killed at a congressional hearing. If the president is Democrat and the Congress is Republican, you get killed at a congressional hearing. So what you need to do is to realize that it's nothing personal, it's strictly business, and when you have to duck, duck. That was my lesson of being in the Congress. In addition, what we have, whoops, I can't believe I didn't turn that off. The other was the extraordinary interaction that I've had the opportunity of dealing very closely with 5 separate presidents, and in the next 3 months, it will be the 6th president. I could tell you stories that go well beyond the time limit, so I won't, but I want to point out a couple of particular things. These are pictures of me at various interactions with presidents, but let me tell you why the leadership of a country has a very important impact on how you respond to certain things in health and science. This is a picture of George H.W. Bush, who, when he was vice president and getting ready to run for president, unlike President Reagan, who manifested very little interest in HIV/AIDS, he wanted to know how the United States could respond appropriately. So he came and visited me at the NIH. I spent half a day with him. Now, for presidents of the United States, 5 minutes is a lifetime. Half a day is an eternity. And he got very interested in HIV, and we became, lucky for me, very close friends. And one of the rules in Washington is be nice to everybody because you never know where they're going to wind up. And presidents turn out to become, vice presidents turn out to become presidents. So when he became president of the United States, he maintained his intense interest in HIV. And here's a picture of he and I and Sam Broda from the Cancer Institute and Barbara Bush, his wife, on the wards at the NIH, the first time a president ever came near a person with HIV. So what I decided to do was to take him around and show him that this is not a disease to be shunned. So we have a patient meeting once every few weeks in our solarium. So I brought President Bush, and all of the people around in this picture are my AIDS patients who got all dressed up to see the President of the United States. And here I am next to him, and he's listening very carefully to the difficulties that they're facing in a stigmatized disease in the United States. That was one of the important things that happened. But another thing that happened that I didn't realize its ultimate significance, which I'll get into in a moment, is that in that room with him was a young man who was his son, who, as a matter of fact, was a staffer on his White House before he became the president of the Texas Rangers, before he became the governor of Texas, and before he became the 43rd president of the United States, and that is George W. Bush. I'm going to get back to him in a moment because he has had a major role in the issue of HIV. But what George W. Bush did, George H.W. Bush, is here's where I first met him. Here is now the funding for HIV/AIDS. It was his appreciation, together with the Congress, of why we needed to pour more resources. So right now, the HIV/AIDS budget for the NIH is over $3 billion. It was trivial early on in those early years. Now, as the director of NIAID, I had the opportunity and the real privilege of leading the effort of the drug development program by forming the National Drug Discovery Groups, the Division of AIDS, and the largest clinical trial network of any disease in the United States. And the results from that turned out to be extraordinary. I wrote an article for the New England Journal of Medicine at the invitation of the editors, asking me the question, I've been talking about ending the HIV/AIDS pandemic and why I think it's possible. And the editors asked me to explain what is the basis of that statement. And my basis of that statement was to follow the science, because the science will ultimately get us there to that end game. And in fact, the science has led to some breathtaking advances in this field. There are over 300,000 HIV-related papers in PubMed as of just a few days ago. That is most extraordinary. The fingerprints of the NIH and NIAID are on most of those, but what they've done is an extraordinary collaboration of scientists throughout the world. So if you follow the science, each of these areas in the yellow boxes, one could spend any amount of time on explaining it, but the one that really stands out the most is the extraordinary relationship with the fundamental basic science and how it led to definable treatments that had an effect on human beings, and that is in the area of treatment. The fundamental science of delineating the replication cycle of HIV and using that to pinpoint targets of vulnerability on the replication cycle, which led to all of the drugs that we've developed, the reverse transcriptase inhibitors, the protease inhibitors, the integrase inhibitors, so that now today, in 2016, we have over 30 drugs which, when used in combination, can transform the life of HIV-infected individual. The picture I showed you several slides ago of me in the room in 1981, the life expectancy of an individual at that time with HIV infection was anywhere from 12 to 15 months median survival. That means 50% of the patients would be dead in 12 to 15 months. Using these drugs now, you can say the same patient in the same room, in the same building, if they come in with early HIV infection and you put them on therapy, you could completely transform their lives. How did we get there? It was a very long journey. In 1987, the first drug showed some efficacy. It was AZT. That was the good news. The sobering news, it didn't last long. It didn't make the patient viremic, and it didn't last long. Several years later, we did a 2-drug combination. The viremia went down further, but again, it was transient. But then in 1996, until the present time today, 3-drug combinations invariably makes a person aviremic, and if they take their drug regularly, it stays that way indefinitely. So that right now, you could look a patient in the eye who 30 years ago you would say, I'm sorry, but your life expectancy is probably going to be measured in months to year, and tell them right now that honestly, if they take their medication, that they would live an additional 50 50 years, which has to go down in medicine as one of the most important advances in the relationship between disease and therapy. Questions were asked. How do you use the drug? Should you be aggressive? Should you intermittently use the drug? Should you treat people aggressively to bring the virus down? The 3 studies I show here are iconic studies which show that if you treat a person who's HIV infected, that's the HPTN 052, and they're in a discordant relationship, you bring down the virus to below detectable level, you make it almost impossible for them to transmit their virus sexually to a sexual partner. It's an extraordinary observation that's true and been proven over and over again. It's better to start early. It's better to continue therapy. In other words, the disease is worse than the drug. And what has happened now is that the observation has led to a guideline from WHO to treat everybody who's HIV infected, regardless of what their CD4 count is. And if you're at a considerable risk for infection, you should be on pre-exposure prophylaxis. Prevention, the same thing. We now have multiple modalities of prevention that actually have been proven to work. Now, years ago, before we even know that there was HIV, we assumed it was a sexually transmitted disease, and we said you should behavior modification. Use a condom because it's likely sexually transmitted. Use clean syringes because we know it's transmitted by blood transfusion. What's evolved over the last 30 years is now we interdigitate treatment with prevention, so that now we have pre-exposure prophylaxis, post-exposure prophylaxis, extraordinary success in the prevention of mother-to-child transmission. How? By treating the mother so that her viral load goes down, the baby doesn't get infected, the mother's life is saved, and there's no transmission by breastfeeding, just by treating the mother. So I'm going to close in the last few minutes on something that really relates to everything I said, is the relationships that I've had the privilege of building up in the government by some of the things I showed you on the slide has allowed me to play a role in something that, as I've told people, despite all of the excitement that I have about the science that I've done, if one was to pick out one thing that I feel in my mind had an important impact, was the fact that I was allowed by the intellectual generosity of people in government to do something unusual. And that is the birth of the President's Emergency Plan for AIDS Relief, or PEPFAR. Some of you may know about this program. It's a most extraordinary program. In 1982, President George W. Bush, who I got to know very well for a variety of reasons, sent me to sub-Saharan Africa here with then Secretary of HHS Tommy Thompson. And he called me into the Oval Office one day and said, I want you to go to Africa and see if you could put together a program that's transforming, that's accountable, and that will save as many lives as we possibly can, because I believe that as Americans in a rich country, we have a moral obligation to take care of those who are not as fortunate as I. And of course, he had known, and I had told him, that 67% of all the HIV infections were in sub-Saharan Africa. So I went to these countries, and I spent time there trying to find out, is it feasible in a developing world to put a program together that you could give drugs to people where they would have to take every single day. There was a lot of skepticism in the United States and elsewhere, I think based on false assumptions of what people can do in a developing world, that you could do this. So here's a picture of me in a hospital in Kampala, Uganda. I got a terrible deja vu there, because these were individuals taking care of AIDS patients in 2002, and they had no drugs to give to the patient. So it was like I was in 1981 when I was taking care of patients and I had no drugs. The only difference is that now there were drugs available. They just didn't have them for them. So to me, that was the big wake-up call that we could do it. The question is, could they deliver drugs? They told me yes. I said, prove it. This is an example of an 18-year-old girl who works for the AIDS service organization run by Alice Coutinho in Uganda, who took me out into the bush. That pack on the back of her motorcycle is full of drugs that were bought by people purely out of philanthropy. This was not a program. We brought it to a village, and we actually delivered the drugs, and they took it. I became completely convinced, totally, that if we put resources into it in a program, that we could actually get sub-Saharan Africa to be part of the treatment and prevention program. So I came back to Washington, and I spent the next 8 months going back and forth at least twice a week to the White House, and I show the picture of this person because I don't think anybody in this room has ever heard of him. His name is Josh Bolten. He was the chief of staff to the President of the United States, and he had a passion that we could do this. So he gave me complete access to getting into the White House literally twice a week to put together the program that we would sell to the president. And as it turned out, over a long period of time, we put together a program to aim at preventing 7 million infections, treating 2 million people, and caring for 10 million individuals. The question is, would the president buy it? I proposed it to him. I said it would cost $15 billion over 5 years. And to my great satisfaction, right at the last minute, he called me down to the White House and said, I want you to be down here for the next 24 hours because we want to put together the wording of how I'm going to announce it in the State of the Union address on January the 28th, 2003. And he did. He announced what we now call PEPFAR, or the President's Emergency Plan for AIDS Relief, which over the last several years, 9.5 million people are on antiretroviral therapy, and more than 1.5 million babies have been prevented from getting HIV infected by this program. And so I want to close by showing you this slide and telling you a 20-second story about it. I was at one of those highfalutin dinners in Washington, and I happened to be sitting next to the editor of the editorial page of the Washington Post. And I was railing on to him the way I am to you about why we can end the HIV/AIDS epidemic. So he turned to me, maybe because he wanted me to just stop talking to him, and said, all right, why don't you just write an article, an editorial in the Washington Post? So I took him up on his suggestion, and I did. And I entitled it, No More Excuses. We have the tools to end the HIV/AIDS pandemic. And though I'm talking to you about things that have been accomplished and done over the last 35 years, the ball game is not over. If we do not implement with the scientific tools that we've developed over the last several years, history will judge us very harshly for not doing so. Thank you.